and welcome to another podcast. Today we're going to talk about blood test analysis. This lesson has been requested by a few people in Replast, because obviously working in the clinical field there are a series of blood tests that you can analyse, and if you have a general understanding of what you're looking at, it can help understand the state that the patient is actually in. So today we're going to go through a lot of common blood tests. We're going to split the blood up into components and then talk about each components in the tests, common tests anyway, associated with them. Now, we're not going to talk about normal values of those particular tests. Main reason for that is depending on the lab that the test goes into, the results will vary. And if we start talking about results, then we'll need to start talking about conversion calculations, and the lesson will go for far too long. So we'll just look at what the actual tests are looking at when the results come in. So before we move into the actual tests themselves, we'll just talk about the composition of the blood and the way that the blood is often separated in order to get a lot of these tests. So the main component of the blood is obviously plasma. Now, when you get certain test tubes like the SSTs and you put them through a centrifuge, you have a separation of formed elements, and then you have the plasma on the top. So at the start of the lesson we'll talk about all the tests associated with plasma itself, or things that are generally found in plasma, and then we'll move on to those formed elements. So the buffy coat, what's found in there, and then the erythrocytes and platelets themselves. So speaking of plasma, obviously plasma is mostly water depending on someone's hydration status, and its main job is to carry the proteins. So a huge componentry that's found in plasma is the proteins. Now that's either liver proteins like albumin, or it can be your globulins, which is your antibodies or your lipoproteins. And then you also have your clotting proteins like fibrogen as well. Okay, so they're all carried in your plasma. The main job of plasma is the distribution of body heat. Obviously being 90% water, it's highly effective at retaining body heat. Now this is very handy given that 60% of all energy that is produced is just to maintain a body temperature. If it wasn't for plasma and the effectiveness of plasma in the water, then we would have to expel a considerably more amount of energy just to stay warm. But on top of that, it's also the main highway that transports all the wastes, nitrogenesis waste. It transports the nutrients and electrolytes around the body for the cells. It's also responsible for most of the transfer of respiratory gases, especially carbon dioxide. And as we mentioned those before, those proteins. Now, proteins can be found as normal protein, albumin, globulin, fibrogen, but you can also have hormones and enzymes that also travel around the plasma itself. So speaking of proteins, the first protein that we will look at is our immunoglobulins, okay, also known as antibodies. Okay, so these are glycoprotein molecules that are produced by plasma cells, okay, so the white blood cells. They act as a critical part of the immune response by specifically recognizing and binding to particular antigens. Okay, so for example, bacteria, viruses. Now when you do a blood test that is looking at antibodies, they're often used as a collective anyway. If you're looking at all antibodies, they're often used in detecting or monitoring something known as monoclonal gammopathies, which is just a fancy way of saying abnormal protein production. Okay, and it's also very handy for looking at things like immunodeficiencies. Now the conventional way to look at these particular globulins is to put it through a serum protein electrophoresis. And when you do that, you can see that there's 5 different types of immunoglobulins. Okay, now as far as abundancy goes, 80% of these immunoglobulins around that will be IgG, and then you've got 15% IgA, about 5% IgM, and only 0.2% of immunoglobulin D and E. Now, if you're looking at them as a collective, if you have elevations of Ig, G, A and M, whilst it can mean just a general illness itself, and we'll get more into that later, it is also the marker that you look for when you're trying to find out or monitor those gammopathies that I talked about. Whereas if you have a elevation in G, A, D and E, it's more characterized by myelomas and things like that. Okay, so just generally looking at it, you can also just have a general serum increase when you're dealing with hepatitis or liver cirrhosis as well, because then there's no control of the actual production or the signals that produce these particular antibodies. Now, looking at the individual antibodies themselves, IgM is a pentamer, which means it's the largest one. So that is the first one to be produced in an active antigen infection. So as soon as infected by a bacteria, then IgM will be produced en masse because it has the most amount of receptor sites, meaning it's able to collect or bind with the antigens faster in order to heal or help rid the pathogen. Now, IgA is a special form of antibody. It's found mostly in the mucous membranes. Okay, it comes a little bit after IgM in active infections, obviously usually associated with the respiratory system. IgD is a little bit unique. It's found on immature B cells, and it only represents about 1% of all the functional receptors on the surface of B cells. So it's just like a little added bonus of potential antigen finding capability for these immature B cells. IgG is your main antibody found in your body, as mentioned, and this represents your memory antibody. So if you want to know if someone has immunity for a certain disease, then you can look up IgG. Now, the most classic one that we often look at in the military is looking for IgG for your varicella zoster, okay, your chicken's pox virus itself. So IgG will hang around. If you test for that and you have positive IgG, it means you're immune. If you have positive IgM, it means that you actually have the infection. Now, the last one is IgE, and that is associated with allergies. Okay, so it's IgE, when that binds to something, it will actually cause the mast cells and the basophils to release their histamines. Okay, so it's part of that particular chain. Other types of plasma proteins we can look at is the proteins associated with coagulation. So there's blood tests known as coagulation studies, and we'll talk about the two main ones afterwards. We'll just mention a little bit about the clotting cascade. So obviously, as you'd know by now, and if you don't, you can go back to the previous presentations I've done on the blood and on inflammation itself, and you can look at the coagulation side of the house. You'll know that there are intrinsic pathways and extrinsic pathways. Intrinsic pathways involve things that are naturally found in the blood and are triggered in the absence of injury. This is what causes your thrombosis to occur on the side of the actual plaqued walls. And then you have your extrinsic factors, which involve vascular injury and tissue damage. Okay, so it's much faster at getting to the point of factor 10A before we move on to prothrombin becoming thrombin, moving down to finally make your fibrin. Okay, so certain tests that you can look at is there's things like antithrombin 3, factor 8 analysis. You can just look at the number of fibrogen. There's also big gross tests like bleeding time, okay, and that's generally looking at less than 9 minutes, and that's mostly testing for problems associated with vascular wall defects, certain drugs that have been put on board like your sacchalates, and also generally speaking just a decrease in platelet number. There's also your activated clotting time, which is generally just literally as it sounds, how long does it take for your blood to clot. And then you have things like thrombin time. Then you can move into very broad type ones, often used in PE and DVT. Now, a lot of studies have come out to show that it's not very effective, but the D-dimer is a test, or was a test, that was commonly used for PE and DVTs. Now, obviously, we're getting a little bit more fancy, and we start to get a lot more specific. But the main ones that you will use in your clinical well is your prothrombin time, also known as PT, and then your partial thrombomblastin. Now that is PTT. Now the difference is PTT uses the coagulation factors mostly found on the intrinsic pathway. Okay, so it's testing the clotting times for the intrinsic pathway before prothrombin becomes thrombin. Okay, and the time that it needs to take in order for that to occur. Now your prothrombin time is testing your extrinsic pathway mostly, okay, and this is often done, especially when people are on warfarin. So if people are taking warfarin, they will do constant prothrombin times, and then they'll convert it to what's known as an INR, okay, or an international norms ratio. Now, when people are on warfarin, you have a therapeutic range. When people aren't on warfarin, then it's what's known as a normal state. Normal state is between about 1 to 1.2, whereas the therapeutic range is between 2 and 3. If someone has a prothrombin time of 6, then generally it means that someone's gone very, very heavy on the heparin, and you really need to give the reversal, stop giving heparin, and go from there. So bedside PTs are often done when someone's getting your anticoagulant infusions. Okay, we'll now move on to something a little bit different, and we'll look at fats and proteins, and a mixture of fats and proteins, which is commonly known as cholesterol or your lipid screens, things like that. Now, cholesterol, triglycerides, and high-density lipoproteins are very important constituents for lipid fractions of the human body. So, cholesterol is it's an unsaturated alcohol of a steroid family, and it is absolutely essential for normal function of all animal cells. Okay, and it's a fundamental element of your cell membrane. Okay, it's also critical in the production of certain hormones, like your adrenal hormone or your sex hormones. Now, triglycerides are fatty acids attached to a glycerol. Okay, and they're the main lipid component of dietary fats, and that's what makes up your adipose tissue. Now, all unwanted or unused calories, if you will, are converted into triglycerides. So it's often, high triglycerides are often associated with heavy sugar intake, believe it or not, especially fructose. Any fructose that is not used is easily converted to your triglycerides. Now, your cholesterol or triglycerides, because they're non-polarized lipids, meaning they're insoluble in water, they need to be transported by plasma protein. And these things are called lipoproteins. Now, lipoproteins are generally separated based on their hydration density, their mobility, ability to move, and then their size. Now, believe it or not, they're actually broken up into 5 major categories. So you have your chylomicrons, then you have your very low density lipids, your intermediate density lipids. Now, those 3 is generally what makes up your triglyceride reading. And then you have your low density lipid and your high density lipids. Now, when you're looking at the blood test, you'll have a series of different numbers, usually 4 types of numbers. What you'll have is you'll have total cholesterol, which is the sum of all your blood's cholesterol content. So all those 5 components, all added up into one. Now, generally, you want that less than 200, and there's certain risk factors associated with higher levels. Now, over the years, so in the past, cholesterol used to be attributed to a major feature of your cardiovascular risk, to the extent that it was taken as a standalone, and if it was high, you will put it high cardiovascular risk. But modern times, they now put it in associated with a lot of other comorbidities associated with cardiovascular risk, and it creates part of a number. Now, your high density lipids, they're called your good cholesterols, because they're the ones that help carry away the LDL cholesterol from the arteries, thus keeping the arteries open and free of plaque. Your low density lipids, well, they've been called your bad ones, because if you have too many of those in your blood, it causes a build-up of your fatty deposits, and that's what leads to your atherosclerosis, and therefore an increased risk of cardiovascular strokes, things like that. Now, triglycerides, as mentioned, they're converted from calories, and they're usually associated with people that are being overweight or eat way too much sweets, drinks, alcohol, smoking, and sedentary lifestyle. Also having diabetes and elevated blood sugar generally plays a role in someone's triglyceride levels. Another very common test that is conducted is the tests that look at common proteins and enzymes that are produced by the liver or controlled by the liver. Okay, so looking at our liver function test, we have a series of blood liver enzymes and then a series of products that somewhat get processed by the liver, but mostly get excreted by the liver, and then the main protein that gets produced by the liver. So starting with the blood liver enzymes, we have ALT, so your alanine aminotransferase. Now this one is your most specific enzyme when dealing with liver injuries. Okay, but however, it can also be elevated if you have heart, pancreas, kidney, or even muscle injuries. Okay, so you need to take it into account with the rest. Now your ASTs are very similar to your ALTs, however they're less specific. Okay, because they can also be elevated with, your heart and your muscles, but then you also have things like lung problems, bone problems, kidney injury, even associated with vitamin A and red blood cell problems as well can cause an elevation in AST. So both to do with liver injury, okay, but ALT is the most sensitive one and AST often complements it. When we move into our GGTs, okay, they're more associated with the biliary tract. Okay, so they're more responsive to obstructions of the biliary tract than the AST or the ALT. Okay, they can be elevated when you're dealing with chronic liver failure, and they can have a mild increase from certain diseases and the use of NSAIDs as well. The last one is your ALP, when you're dealing with your liver enzymes, and they're also associated with the liver and the biliary duct. Okay, so they're very non-specific because all the ones that we mentioned before for elevations, kidney, bones, lungs, can also have a increase in your ALPs, but then you also have things like ectopic tumor productions, can also have a false positive for ALPs, or false positive in the sense for the liver itself. Okay, from there we can look at our bilirubin itself. Now bilirubin can be broken up into total, so how much it is completely, and then you can also have a direct, which is also known as a conjuncted bilirubin. Now that is obviously associated with a decrease in bilirubin excretion, so things like liver disease, alcohol toxicity, cancers, primary cirrhosis, cholelithiasis, obstruction of the biliary tract, things like that. They're the most common ones when you're dealing with adults. When we look at the indirect, okay, or the unconjunctated bilirubin, that's more got to do with red blood cell hemolysis. Okay, so things like sickle cell anemia, G6PD deficiency, especially if you're giving certain medications, and it can also be associated with liver disease, more like hepatitis or hepatic congestions from congestive heart failure itself. Now, albumin is a protein that you can look at by itself. Okay, but another test you can do is just looking at a total protein. Now, the problem with just looking at albumin itself is it can have nothing to do with the liver. So you can have a decrease in albumin level just because you have a decrease in intravascular volume. So if you're bleeding, you're going to have a decrease in serum albumin because albumin is the most abundant protein found in the plasma. If you look at total protein, then you can look at actual abnormal protein production. Okay, so the gammopathies that we talked about before. And then you can also look at certain drugs like androgens. Okay, you just need to be aware that when you're looking at serum protein, things that are non-pathogen related, like decreased intake, decreased absorption, or decreased synthesis of proteins, can actually be a problem as well. So full malabsorption, liver disease. You can also have an increase in protein for things like nephrotoxic syndrome and burns itself. Okay, we'll now move on from our liver function test, and we'll move on to the history, if you will, of cardiac markers. So over the years, scientists have come up with different ways in order to detect cardiac damage. Okay, so it started with the AST that we won't even speak about, and then we moved into creatine kinase, and then your lactic dehydrogenase, which is your LHD. Now, creatine kinase is still sort of used, especially in conjunction with troponin, but LDH is pretty much no longer used. Now, LDH is a sensitive test, but it's not specific. So other causes of increased LDH includes hemolysis, liver disease, renal disease, and skeletal muscle damage. Okay, you can also get it with pulmonary emboli itself. Now, the overall goal in using cardiac markers is to find something that is specific to the cardiac tissue that is not found in the other muscles, smooth muscles or skeletal. Now, having said that, myoglobin is obviously found in both skeletal and cardiac muscle, and it's the main protein of striated muscle, so it's not very specific at all. Okay, so limitations of use of myoglobin are that it's not cardiac specific, and that it's rapidly excreted by the urine as well. Okay, so causes of increased myoglobin can be rhabdomyolysis, skeletal muscle trauma, surgical procedures, seizures even, burns, and obviously crush syndrome. But one advantage that myoglobin has as a serum cardiac marker is it's likely to be the first to rise above normal after an acute MI. Okay, so usually within 1 to 4 hours of an infarct event, you can find isolated myoglobin measurement. Now, whilst this does not confirm diagnosis of an MI, myoglobin should always be used as a supplement for other cardiac specific, like your CKMB and troponin. Now, CKMB was invented in the 80s, but is still used today, especially in conjunction with troponin. One of the advantages CK, so creatine kinase MB, has over other markers is that it remains elevated for longer periods, and it's easier to detect reinfractions using CK and MB measurements. So following myocardial or skeletal muscle damage, both CK and CKMB levels will rise. To aid in differential for cardiac from skeletal sources, what is often done is they calculate CKMB as a percentage of total creatine kinase enzyme, and it is often used in conjunction with troponin. Now, troponin was a real game changer because troponin itself is actually a regulatory complex of 3 different protein subunits, which are located within the thin filament of the myocardial contraction. Okay, so it's actually found in the actin of the myocardial contractile apparatus. So the sliding filament theory that we've all heard about. So the 3 subunits are troponin C. Now, this is the calcium binding site, and then you also have trypamycin binding component, and then something known as the inhibitory component. Now, the advantage is the amino acid sequence of skeletal and cardiac isoforms for 2 of those components are significantly unique. And it's because of their unique formation, it actually allows us to find markers that are more specific to cardiac. Now, obviously, because of the calcium binding site, which is found in skeletal muscle, there are still some false positives. Okay, but in 2010, as you can see, you have a highly sensitive troponin that came out, and this really increased the numbers. So looking at the numbers, high sensitive troponin tests can have a 99% sensitivity for myocardial infarction. Okay, we'll now take a break from things that are found in the plasma, and we'll start looking at that buffy coat. Okay, so we'll start with our white blood cell analysis. Okay, so the evaluation of distribution of white blood cells is one of the most valuable procedures that can be done by the examination of the blood. The information obtained may actually lead to diagnosis and serve as a guide for therapy, and it can also be used to indicate harmful effects of certain medications like radiotherapy or chemotherapy. Now, when the white blood cells are written as percentages, as you see, the relative percentages is based on a differential count of 100 white blood cells and refers to the percent of each type of white blood cells that can be calculated. Now, the normal state is written as you see. So the most abundant of white blood cells is your neutrophils. Now, these are obvious, the ones that rock up first, and then you have your lymphocytes, your monocytes, eosinophils and basophils. Okay, that is the normal number. Now, the total normal number of white blood cell counts, difference depends on the lab, but the higher numbers generally always 11,000, and the smaller number when we start to get worried is around 4,000, but 8,000 is generally the norm that we'll find. Now, each one of these white blood cells obviously have a different role that they'll play, and we'll look at that now. So the first one we'll look at is our neutrophils. Now, as mentioned, this is the most abundant. So these are the first ones to rock up in any presence of inflammation or any presence of infestation. They're mostly used for phagocytosis, early phagocytosis of bacteria and fungi. So high numbers of neutrophils are normal. Okay, now these are the ones that will float around the bloodstream, and they're the first to be attracted by the chemotaxis that is released if there's any tissue damage itself. Eosinophils are unique. Okay, they're not very abundant in the bloodstream normally, and these are associated with parasitic infestation. So eosinophil numbers will increase if you have a parasite like a worm that is causing a problem in your body, because what they do is these tiny little eosinophils will actually land on the surface of the worm, and they'll inject lysosomes onto the parasite, will actually start digesting the worm itself. Basophils are another small number base white blood cell, and these are heavily associated with the histamine response. Okay, so they release histamine, and they also release heparin when they're drawn to an area. Okay, so they're drawn to an area along with mast cells, and they're used to release the histamines, which obviously causes the vasodilation, which is used to attract more of the white blood cells to clean up the area. So if you have allergen-based responses, then an increased number of basophils are likely to be found. So if someone has chronic hay fever or chronic allergies, and you do a blood test, you're likely to find an increase in the basophil number. Lymphocytes are those very specific white blood cells, and they're the ones that are used to create your specific immunity. Okay, so they're the ones that either will become natural killer cells, or they'll become B cells or T cells. An increased number in these is often associated with a long-term infection, but as with most of the white blood cells, you can actually look at the morphology changes of these lymphocytes in particular in order to pick up early formations of neoplastic growths. Okay, so it can be used as an early marker for cancer screening. So looking at the shape, the nucleus morphology of these particular white blood cells can tell scientists a lot whether or not they're immature, whether they're neoplastic, and it can be used as an early marker to detect cancer. Okay, and the last one we'll look at is the monocytes. And monocytes are mostly used for phagocytosis. So when they're in the bloodstream, they're known as monocytes. But when they get activated in the bloodstream and become macrophages, they often move into the tissue and the lungs. Okay, and these are the main white blood cells that are associated with gross phagocytosis. As I mentioned before, looking at the sheer numbers of these white blood cells can tell us a lot with diagnosis, but under a microscope, scientists are trained, especially back in the old days, used to be trained to look at the actual morphology of white blood cells in order to pick up changes, whether or not the white blood cells were immature and not fully developing. You can also look at acquired non-neoplastic alterations or inherited non-neoplastic alterations. And then, of course, there are the neoplastic white blood cell alterations. Now, we won't go into too much details with that, but if you are interested, you can look up white blood cell distribution and morphology, and it will show you all the structural changes, especially within the nucleus or the granules themselves, that denote different types of pathological states or infestation itself. Okay, to finish up, we'll just have a quick look at our red blood cells and some of the tests that we can conduct associated with red blood cells. So if you take away the water component of red blood cells, they're pretty much fully hemoglobin. Okay, they're very tiny structures and they're biconcave discs, okay, which means they have an increased surface area to volume ratio. Now, certain tests that can be conducted when we're dealing with red blood cells. Firstly, the main one that is often done is your hematocrit. Now, hematocrit is defined as a proportion of red blood cells to plasma within a sample of blood. Okay, so following the collection, it's obviously spun in a centrifuge, and due to their weight, the red blood cells will be forced to the bottom of the tube, and you will determine a percentage from there. Now, hematocrit can be used to assess the extent of a patient's blood loss. Okay, and generally speaking, a drop of about 3% hematocrit equals about a unit of blood loss. Okay, now you need to note that as a result of a large blood loss, you're not going to have a decrease in hematocrit immediately, okay, because you will lose equal portions of red blood cells and plasma. Okay, but over a period of time, when you get the shifting of fluids from the interstitial and the intracellular space into the intravascular, you're obviously going to have a diluted version of the hematocrit, and then you can use it, its relative percentage, to denote how much blood was actually lost. Now, hematocrit is really only useful if the patient is hydrated, okay, or has normal hydration. If they're overhydrated, it's not useful. If they're underhydrated, it's not useful. Okay, so it's often used and associated with other numbers. Now, the mean corpuscular volume, or MCV, is a measurement of the average red blood cell size. Okay, so if it is elevated, the red blood cells are larger than normal, okay, or what's known as macrocytic. This occurs in macrocytic anemia for those that are due to mostly a vitamin B12 deficiency or a folic acid deficiency. Now, if MCV is decreased, obviously it means that the red blood cells are smaller than normal, or microcytic. Now, microcytic conditions include iron deficiency, mostly. It's mostly going to do your iron deficiency anemia that will cause your MCV to be lower. Now, mean corpuscular hemoglobin is often measured as a concentration. Now, this is measuring the concentration of hemoglobin content relative to the size of the cell. Okay, so it's obviously the hemoglobin concentration per red blood cell. Now, infants, especially neonates firstborn, will naturally have a higher MCH. Obviously, this is needed in order to create a concentration gradient, so the baby can actually get mum's oxygen. Now, decrease, as you'd imagine, it's got to do with anemia from chronic diseases, and also iron deficiency, and from memory, things like lead poisoning as well will lower your hemoglobin concentration. Okay, the last one we'll talk about is the erythrocyte sedimentation rate. Now, this is a very non-specific test used for inflammation and necrotic conditions. So ESR may also be increased in things, situations of physiological stress like pregnancy. So in these types of conditions, there is a change in the blood proteins, which leads to a clumping of the red blood cells. Okay, so when you're in states of necrosis or inflammation, your red blood cells will clump together. Now, the ESR measures the speed in which the erythrocytes settle to the bottom of the tube, exactly as it sounds. So when the tube is mixed with anticoagulants, the cells which have clumped together due to inflammation or necrotic conditions settle more rapidly than single cells. Thus, ESR is expressed in millimeters per hour, and it would be increased if you have inflammation or necrosis. Okay, so that finishes this presentation. It's a quick one. Like I said, it's an overview of some of the common blood tests that we do, and mostly focusing on what the test is actually testing for and how it can be useful, and not really looking at the numbers value, because as I mentioned, the numbers will change depending on the labs and depending what test has been ordered. There's some slight differences, especially when you get into ions as well. But the good thing is most tests that come out from the pathologists these days will actually have the normalized range beside it, okay? And anything that is elevated will often be highlighted as well. So it's more important that you know what you are looking at as opposed to trying to remember the numbers. Okay, so until next time, take care.